Welcome to the EAU podcasts. In this episode, UROONCO Bladder Cancer Chief Editor Dr. Pradere talks to Professor Roupret on the results of the ALBAN trial.
Good morning, everyone. It's a pleasure to be today at ESMO 2025 in Berlin. I have the pleasure to be with Professor Morgan Roupret today. Welcome, Morgan.
Thank you for having me.
It's a pleasure to have you at UROONCO podcast because you have presented today the ALBAN trial, the trial that you have performed in France and in other countries in Europe. Can you give us a bit the rationale behind this trial and why did you do it?
Yes, actually, when we saw the checkpoint inhibitors coming to the market, they were the new kids on the block in the field of urothelial cancer, we thought that it should be logical to test the possibility to use the checkpoint inhibitors in a localized disease because it was only at this time developed in metastatic cancer. So we had an initiative together with Johan Loriot, with a medical oncologist. We discussed with the French network, the CCFU and the GETUG, and which is very active in the field of GU cancer, especially in prostate. And we had the opportunity to trigger this trial 8 years ago. We didn't know at this time that we would have to face the shortage in BCG plus the COVID-19 outbreak, which was a nightmare for the recruitment of the patient. But ultimately, we did it. We recruited more than 510 patients. The vast majority of them were recruited in France, but also in Spain and in Belgium. So it is clearly a European trial driven by the French phase 3 trial with a regular arm, population of non-muscle invasive bladder cancer, high risk according to the EAU stratification guidelines. And regular arm is transurethral resection of the bladder plus re-resection or second look in case of T1 plus BCG induction and maintenance. And the experimental arm, as a cherry on the cake, you will add the atezolizumab every 3 weeks for 1 year. So the particularity of this trial, which is academic, is very pragmatic for the patient. And one of the singularities, the differences with the other trials, is that the endpoint has been defined by any recurrence, because any recurrence you would see at the cystoscopy as a urologist, you cannot know the grade and the stage without removing it. So you will do a TURBT. This is the point. So actually,
included low grade, high grade.
Any tumor that reappears, yes, which was not the case in other trials. It's important because what we are talking there is the primary endpoint. The primary endpoint is EFS, event-free survival. What is an event when it comes to localized disease? It's not a metastasis. It's not removing the bladder. It's another tumor. So it's another TURBT. So from the beginning, we made the choice, and we also know that it is very difficult to have a length of BCG maintenance over 1 year for the tolerance of the patient because of the side effect of the toxicity. So this is why we designed the trial this way. And ultimately, the EFS, the first endpoint, the hazard ratio was close to 1, so there was no difference between the experimental arm with the addition of systemic atezolizumab. On the event, we recruited the same number of events in each arm. Even when we look at the forest plot and we stratify according to the existence of carcinoma in situ. And the other thing is the evaluation of the toxicity that we generate, because it will be the key issue in the debate. And I'm not so sure that the 3 trials are going to solve this debate at the moment. We have much more open a Pandora's box around this discussion. So we had a lot of treatment-related adverse events of grade 3 and 4. A large proportion of them were coming, of course, from the systemic treatment. So the question today is whether or not we need to balance the choice of a systemic treatment for a long period of time compared to, I would say, a local treatment. At the moment, ALBAN is negative. We have no mature overall survival data. But for the 2 first primary endpoints, which were EFS and recurrence-free survival for high grade, it's negative when it comes to the hazard ratio.
Would you say that we are in 2025 still keeping BCG as the standard of care? Is it long life to BCG again?
BCG is cheap, is here to stay in my mind, has not been challenged yet, and no drug in the pipeline, either in the intravesical route or in the systemic route, is coming head-to-head against BCG. It's coming on top of BCG, after BCG. So the next big thing in my mind is to challenge the maintenance regimen that we propose. I would go definitely for a trial with induction of BCG and after a new type of maintenance, TAR200 or any nadofaragine, crestimogene, whatever you can consider. But I think the first, I would say, step is to keep the BCG.
Do you think that in the next coming years, there are some expectation to have in terms of new drug developments that we have to look at for BCG naive, in the BCG naive setting?
Yeah, in the BCG naive setting so far, what we can see and what we can say, not only from ALBAN, but from POTOMAC and CREST, is that there may be a small population of patients which is likely to be suitable for the systemic treatment, very high risk and so on, but the trials should have been designed for this population from the beginning. So we'll see. But I think the intravesical road appears to be the way to go. And we need to move on and expect to have some ancillary data from these big trials on the molecular marker. So we'll come back to our colleagues with that because we have seen that the field of personalized medicine, which was open with the FGFR mutation research, is opening a new era in the categorization and selection of the patient.
Thank you very much, Morgan. Last question. You have been for more than 10 years in the EAU guidelines. You are the chair of the French guidelines for oncology. What is your recommendation? At least, how would you see this kind of data from CREST, from ALBAN, and from POTOMAC in the guidelines for our colleagues?
Yeah, to be very straightforward, big trial, so it's impossible to neglect these debates. You cannot put it in the trash. It has to be mentioned in the guidelines. It's very difficult to make a statement at this moment and a strong recommendation. But for sure, I believe, I told you, a subgroup of patients will be candidates. So I think the recommendation will be, please discuss any case if a super high risk case and systemic treatment could be or should be proposed in that category of patients. So it will be a yes, but only for a few of them.
Thank you very much, Morgan. I'm sure that it will be this way for the next coming years, at least because of the toxicity. Thank you very much for your time.
Thank you.
Thank you for listening to this episode of EAU Podcasts. To keep up to date with bladder cancer developments, visit our educational platform, UROONCO Bladder Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.